So welcome everybody to today's Bite. I have the lovely Rebecca Thompson with me, who has actually got an organisation called Your Menopause. So Rebecca has come to join us today to discuss menopause. You know, one of those topics that is often not discussed very well, and also a lot of women struggle through menopause and don't know where to go for information or might be getting the wrong information. So Rebecca's going to share with us her passion and her knowledge and her experience with working with women through this stage in their life. Before we start, I would like to acknowledge the Whadjuk people of the Noongar Nation, the traditional custodians of the land on which we work. I acknowledge the elders past, present and emerging, and the continuing cultural, spiritual and religious practices of the Noongar people. I would also like to acknowledge the traditional custodians on the lands from where you may be listening to this presentation from, and the other Aboriginal nations represented here today. And in the spirit of reconciliation, I acknowledge our non-Aboriginal colleagues who walk beside us. So welcome, Rebecca. It's lovely to have you on A Bite.
Thank you very much, Veronica, and thank you everyone else who's listening in. I'll start by telling you why I have Your Menopause. I'm actually a registered nurse who's been working in education for many years. I'm also a health and wellness coach and the owner and founder of Your Menopause. I've been working in the area of menopause now for the last 4 years in WA. And the way it all started was basically I was going through perimenopause and wondering, was there anyone else out there who was experiencing what I was experiencing? Because it's one of those things that people don't really talk about a lot, especially 4 years ago. Definitely things have changed or are changing now. But I wanted people to, or other women and men, to know what was happening and what's happening to their body and be aware of what treatments they can seek to get help so they're not struggling through menopause. A friend of myself and I started a group called Embrace Change 4 years ago, where it was developed to support women going through menopause, encourage them to connect with other women so that it didn't feel like they were alone, as well as looking at treatments that are evidence-based as well, because there's a lot of information out there, but a lot of it is not information that perhaps is useful to women. So when I put up this screen, menopause, what does it mean to people? There's a myriad of things that come to people's mind. Mostly when I put this up, women will say, or people in the audience will say, well, getting old, taboo, something we whisper about but don't really talk about. Hot flushes, so some of the symptoms that people experience, mental health issues that come along as well with menopause. So there's a lot of things that are brought up by this word menopause. I think things are changing, absolutely. I mean, the fact that we're talking about menopause in a workplace wouldn't be happening 4 years ago when I first started. So people are talking about it now a lot more. I think still the mental health aspect of perimenopause and menopause is still something that needs to be spoken about more. There's a professor called Professor Kulkarni in Melbourne, and she's a psychiatrist and specialises in women's mental health. And some of her research has shown that suicide rates of women within the perimenopause stage, which is between the ages of 40 and 59, is the highest level for any other age group of women. And actually it's the highest age group for suicide in Australia, behind men over 80. So men over 80 first, and then women in their menopausal ages. Not to say suicide has occurred because of menopause, but you've got to start to think what else is happening during this stage. So it's a high-pressured stage of a lot of women's lives, and it's serious and it can affect us in so many ways. So let's have a look at some definitions. What is menopause? Let's look at, first of all, I want to really highlight in this slide that it's not something we should be looking at with regards to age necessarily. We've got to really focus on hormones rather than age, because so many times the women I work with say that they've been to see a medical professional who said to them, no, you're too young to be going through menopause, and they kind of leave despondent thinking, but I'm sure that's what I'm experiencing. So it's really something really from this video, from this screen, I want you to see that every age can be affected. The average age of menopause in Australia is actually 51 years old. Anywhere between the ages of 45 and 55 is considered normal, if you can have a normal in menopause. Between the ages of 40 and 45, that's considered early menopause, and there are a number of women who would be experiencing early menopause at that stage. And then you've got women who are under 40 years of age who are experiencing POI, which is premature ovarian insufficiency. This group of women, you can imagine, have to be looked at more closely because it is a much younger age. And often with these women, you will find that they've gone into premature menopause because they may have been having surgery that's maybe they've had an oophorectomy and a hysterectomy that's removed their ovaries, or they've had chemotherapy or other medical treatments that has affected their reproductive system and put them into early menopause. But there are a number of things and they need to be further investigated. But with those other group from 40 upwards, women are considered, that's a normal stage. But what is menopause? Because menopause is one of those terms, it's an umbrella term that people say, oh, I'm in the menopause, I am menopausal, I'm experiencing menopause. But menopause is actually one day of your life. It's the day you have your last period. For those of us who have had our ovaries removed, or we've got devices such as the Mirena coil or other medications that are preventing us from having periods, we won't know via our periods. So it's also, I guess the better term really is looking at the last time you ovulate or release an egg. This is one day in our lives. But during this time of our life, during perimenopause and menopause, often women's periods are becoming irregular. Not always though. So please remember, if a lady says to you, or yourself even, you've got other symptoms but your periods are still regular, you still could be in perimenopause. So that's just something to remember. But for a lot of women, they are starting to get a bit more irregular. So you can't really just say, oh, today's my last period, because often we won't know. So the way it's measured is waiting 1 year from the last period, and then it's a definition of being that you are menopausal. So it's 1 day a year in retrospect when you had that last period that you're in menopause. But it's only for a day, and then as soon as you're in menopause, then the next day you're in postmenopause, and you will be for the rest of your life. So the really big stages are perimenopause and postmenopause, with this 1 day where you have your last period or release your last egg, and that's when you're in menopause. For most women, actually, the menopause side of things, the day you have your last period, is not such a big deal, because often at that stage our symptoms are settling down. What you are going to probably experience with people you're working with, or perhaps yourself, or people you know, women you know, is they'll be experiencing symptoms during the perimenopausal phase, so the time before you stop having periods. And this time can last anywhere between 4 to 10 years prior to going into menopause. So let's look at the average age of menopause in Australia. It's 51 years old. Let's go back 10 years before that. So that's 41 years old. A woman who's going to have an average menopause in Australia of 51 could start experiencing symptoms at 41 years old. Anywhere between 41 and 51 years old, they'll start to have symptoms. And that's where people are really being affected. And that is why when a woman goes in to see a medical professional and says, I'm starting to experience symptoms, or I'm having, gives them a myriad of symptoms, they've got to start to think, well, okay, it's not age. Let's start to look at what are they telling me? What are their symptoms? So please remember that. So if it's 45. They could be having perimenopausal symptoms way back at the age of 35. So that's really sort of changes that outlook. Yes, they may actually go into menopause at 45, but they'll be having symptoms that are going to be worrying them a lot earlier. So I hope that sort of really highlights that, because they're the ones you'll be seeing. So what's actually happening? Women are managed or controlled by hormones from the moment we go into puberty. But during our reproductive years, our hormonal changes are quite regular for most of us. During our menstrual cycle, we will ovulate and we'll either get pregnant, or we will go and shed our lining of our uterus in the form of a period. And this, as you can see via this slide, is very cyclical for most of us, with peaks and troughs of estrogen and progesterone. Interestingly, for many, many women who have PMT or PMS, which is that kind of week before they have their period where they could feel very teary, quite agitated, could have food cravings, that is actually a fluctuation in their hormones, which is exactly the type of thing that they're experiencing during perimenopause. And that's why it's often saying, I just feel like I've got PMT the whole time, because it's the same thing that's happening within your body with your hormones, that fluctuation. But unfortunately, it doesn't happen in a nice cyclical way like it has during reproductive years. This time is very erratic. And you can see on the slide that once you hit perimenopause, this erraticness goes crazy. It's not a steady decline over the years. It's this fluctuation, often on a daily basis for women. And that's what's causing the symptoms. Now, the way perimenopause is identified is not through blood tests. And the reason why we don't do a blood test to have a look at the estrogen level or the progesterone level is because of this fluctuation. Because if today you did a blood test, you would see that the estrogen level is about the same as the estrogen level during your reproductive years. But the next day, the estrogen level is much, much lower. So it really does depend on the day that the blood test is taken. So it's so difficult with a blood test to identify what actually is happening. So the International Menopause Society, the Australasian Menopause Society, all menopause societies recommend that you go by symptoms. So when a woman is speaking to you, listen to what she's saying. She might tell you that her periods are irregular. She may not. But what she's going to tell you is all sorts of other things. And that's where the symptoms come in, and they're so important to identify what's actually happening to a woman. So if she's sitting in the right age group, so anywhere from 40, 45 onwards or earlier, and telling you these sorts of I'll discuss the symptoms, telling you about symptoms that are happening. She might be telling you that her periods are irregular, or she might not. But they're the things that you're going to be starting to listen out for. Once a woman, like we said, hits menopause, that last period, the hormones have already dropped down quite significantly, and things are starting to taper off. And a lot of women say once they hit post-menopause, things start to go to a new normal and a lot more steady. So that's something for a lot of women to look forward to. So what are these menopause hormones? There's 3 of them. I call them menopause hormones because they're not just sex hormones. They're not just for reproduction. They're actually everywhere in our body and affecting every part of our body. So the hormones are estrogen, progesterone, and testosterone. Women have testosterone just at a lower dose than men. And that does decline from midlife down, but a much more steady, slower pace than, say, the estrogen and the progesterone are happening, but still can have some significant effects on women. So you can see here with under each title of the hormones that there are a lot of areas that are being affected. And what happens basically is in the body, they have receptor cells in every part of the body for these hormones. And if we consider a receptor cell like a postbox, I guess, waiting for a message from these hormones to occur. During our reproductive phase of our life, where things are very cyclical and very regular, we get these messages from estrogen, progesterone, and testosterone on a regular basis, and everything's functioning extremely well. When we hit perimenopause, where these levels, the estrogen level or progesterone or testosterone level, are a little bit more erratic, there can be days when the postbox or receptor cell receives lots of messages. And then there's other days where they won't receive any messages. And this is where these symptoms are coming through, and the erratic new symptoms that we've never experienced before starts to occur. I'll give you an example. Eyes. Eyes have estrogen receptor cells that help with, because it's a mucous membrane, helps with lubrication. During perimenopause, when we're not receiving the estrogen message on a regular basis, there will be days where women will say that their eyes stream with, with tears, and they can't control what's going on. Then there are other days where they feel like their eyes have sandpaper in them, and that's when they're not receiving. One is receiving too many messages from estrogen, another is not receiving enough, and that's just one area of the body that can be affected in this way. But you've got hair, brain, lungs, liver, nails, stomach, obviously the reproductive organ, bladder, where women can start to experience far more UTIs. It's because you've got a drop in these hormone levels. So it's something to really be aware of, that it's going to affect every part of the body. And women are going to come to you with many, many different symptoms and explain that to you that they're experiencing. Often they'll say, I just don't feel myself. I don't feel right. I feel like I'm going crazy. Just all those things. I'm exhausted. I've got such fatigue. These are the sorts of very common symptoms that women will explain. So who gets perimenopause symptoms? Most of us, I'm afraid. 80% of us will experience symptoms. There's 20% who won't, and they're extremely lucky, but the rest of us will experience symptoms to some degree. You've got 20% of females who are actually going to experience symptoms severely, and this may be vasomotor symptoms, urinary tract infection symptoms, mental health issues, all those sorts of areas that really affect them extremely on a day-to-day basis and really affect their ability to function. For 60% of the female population, we're going to experience perimenopause and menopause symptoms in a mild to moderate way. Now, don't think mild to moderate isn't significant, because this is mild to moderate on a daily basis. And this can be, can affect our day, affect our lives extremely at this stage, because at this stage of our life, when we do hit the menopausal stage, it's often a time that we are at a peak of our careers. We have ageing parents. We may have, if we've got children, we've got teens or young adults. So we've got pressure coming from many, many levels of our life. Prior to perimenopause, we were coping with this very well. But then with these hormone fluctuations, for many women, this becomes overwhelming. And so this mild to moderate symptoms can really have a vast effect on their daily life. So what are these symptoms? I've been talking about symptoms over and over. Veronica sent out prior to this talk, and you can download it on my website as well, a checklist for menopause. And it's menopause symptom checklist. It's just got a list of symptoms, and I've broken it down into body and mind. It's actually based on some research into the most common symptoms that women experience during perimenopause or menopause, but it is not a complete symptom list. So if yourself or women that you're working with say that they've got other symptoms that are not on this list, don't ignore them. Get them to jot them down and be part of their experience. But these are the majority or the most common ones, I guess. The way I use this with people during talks like this one, or when I'm doing one-on-one work with women, is I'll ask them to take it away, sit down quietly and actually look at which symptoms are affecting them. Going along, they can see as they tick the boxes of what is affecting them, they will start to see which ones are affecting them the most, and also start to realise that these symptoms are happening in connection with each other often. An example of this, which is one of the most common symptoms that women in Australia experience, and this came from a study last year looking at symptoms of Australian women. They said that their most common symptom was difficulty in sleeping. Now, you can imagine if you're not sleeping well and you've got a big presentation the next day at work, or you've got elderly parents to deal with, or teenagers for that matter, that can really impact your day. And if this is happening constantly over and over again over every night, it can have a significant effect. There's also research to show that if you're not sleeping well, you are increasing your risk of developing depression. So this is extreme for many women. Women are often, women going through perimenopause and menopause in that age group are often offered an antidepressant once they go in to see a medical professional, because they'll often go in saying, I just don't feel well, I don't feel right, I'm confused, my head's all foggy, I cry at the drop of a hat, I'm really irritated by what's going on in my life, people irritating me, I've got mood swings and I feel depressed. And they may be experiencing depression, but before reaching for an antidepressant, with a use of a checklist like this, you can go back and actually discuss what else may be occurring that's causing the depression. So, for instance, if a woman isn't sleeping well and she's going to the doctor saying, I'm feeling really exhausted, I'm depressed, I'm feeling down, I don't have energy to get through my day, by investigating and having a look at the checklist and saying, oh, have a look at that, you're actually saying that you're actually having difficulty sleeping. Tell me about your difficulty in sleeping. And if they're saying to you, well, I'm actually getting night sweats, I get really hot in the night and I throw my covers off all through the night, those night sweats are waking the woman up. And the waking the woman up is giving the woman difficulty in her sleep, which is then going to increase her risk of the depression. So you can see, once you explore what's actually happening with this woman, you can see that giving her an antidepressant may not be looking at the whole story. And if you go back to the cause of what's causing her depression, it's actually that she's having fluctuation in her hormones. And this would be a time in discussing, well, let's look at the treatment of having this reduction in your hormones first and see if we can actually make you feel better. And so that's the way this checklist can be used. The other thing is, it doesn't matter what level or what stage you are in your perimenopausal, menopausal journey, these symptoms change all the time. As the hormones are fluctuating and dropping, these symptoms can come and they can go. In actual fact, the vasomotor, so the sweating, the hot flushes and the night sweats can be more common later in menopausal phase as you're getting closer to actually reaching menopause. So having the checklist and checking it regularly, maybe every 6 months, just to see what's changed, what's improved. And also then, if you've still got symptoms, going back to your medical professional with your checklist and saying, look, things are okay, but I'm actually still experiencing this, this and this. Because the whole idea of managing this stage is trying to best manage the symptoms that a woman has experienced. So it's really important to keep discussing it and keep changing the treatments, because often women will be put, if they're put on MHT, menopause hormone therapy, they will be put on a low or moderate dose at first to get them settled, and then the dose will be tapered or tailored, probably increased to start managing more the symptoms they're experiencing. If their symptoms, despite many changes with their hormone doses, still they're still experiencing symptoms, then maybe other medications may be introduced for women. But this is where the discussion starts. So please download that and pass it on to other people or people women you're working with, to help them start to identify what's sort of going on in their lives. So we've looked at menopause, what it is. We've got the definitions, we've looked at the hormones, and then we've looked at the symptoms that women are experiencing. So once you've identified all this sort of thing, what can we do about it? Well, there's a lot we can do about it. And it needs to be approached in a holistic way, because there are many aspects that a woman can look at during this time of her life. Obviously, diet is important, as it is at any stage of life, but during this time, because it's estrogen is an anti-inflammatory hormone as well, so a lot of women will experience gut issues or pain in their joints. And there's been some research to show that a Mediterranean diet can help with that anti-inflammatory effect. The other thing about a Mediterranean diet, or a good healthy diet, is you're reducing the sugars, the complex carbohydrates, so you're actually having a healthier diet for women. So the diet is something to look at. Exercise is another area of high importance for women, because we're moving into the next phase of our life, which is the importance around that is to stay fit and healthy and upright. For as we're getting older, if we can keep moving, we're going to be healthy. So it may not be that that you want to go into the gym and pump weights like you did maybe in your 20s and 30s, or run marathons. It may be tweaking your exercise to do things that you enjoy. So walking along the beach with your dog, yoga, Pilates. Pilates has been something, and yoga has been something to show that can assist women during this phase, where it's muscle strength building exercises with low impact, which is important for women. Also at this stage, as we talked about the mental health aspects of life and the pressures that women are going through at this stage, it's really important to discuss some form of relaxation technique for a woman. Now, they'll probably say, as most of us would, well, I don't have time to meditate, I don't have time to relax. But it's really highlighting the importance for them to put themselves first, even if it's for 15, 20 minutes a day, where they can sit maybe and have a cup of tea quietly somewhere and just relax, or meditate if that's what they're interested in, or going for this relaxing walk. But something for them just to reduce their stress, the mindfulness part of their lives. We discuss sleep, and sleep is super important, of course, as we discussed, but there is a lot of issues around sleep, so it really needs to be investigated why a woman isn't sleeping. So in conjunction with all of this, the really important thing is that perimenopause and menopause, going back to the definition, is a reduction in hormones. And if we had an insufficiency in vitamin C, what would we do? We'd take vitamin C, we'd take a supplement. If we had diabetes, we would be on, if we had type 1 diabetes, we would be on insulin, another type of hormone to monitor, to regulate our sugars. If we had a low thyroid, or we had problems with our thyroid, we'd be taking thyroxine, another hormone. So these are hormones that we put back into our body when we've got an insufficiency of a hormone. It's just the same in perimenopause and menopause. It is an insufficiency of reproductive hormones, and we replace them via MHT, which is menopause hormone therapy, or HRT as it used to be known in Australia. MHT can come in many, many forms, but the major focus on MHT is if you have a uterus, you need to have protection for the uterus lining in the form of progesterone. So you will be given either oral progesterone, or for those of you who have got a Mirena coil, or women you're working with who have got Mirena coils, that is the progesterone coverage that they will be given. You'll often be given Mirena, or women who have a Mirena coil inserted if they've started to experiencing heavy menstrual loss during this time, which is very, very common. And often one of the first approaches is to try a Mirena coil to control that. So it may be for many, many approaches during this stage. But if you've got a uterus, you need to have some sort of progesterone coverage to prevent the lining of the uterus thickening, and therefore increasing the risk of uterine cancer. For those of you who don't have a uterus, then you don't necessarily have to take progesterone. But as we saw in the previous slide, there are some big benefits of progesterone, so you may be offered that as well, depending on your symptoms. Estrogen is the big one. That is the one that fluctuates a lot and gives a lot of symptoms for women and a lot of distress for many of us. And so estrogen can be given in many ways, but the important thing now to look at is estrogen and progesterone are body identical hormones that are used now, because these are the new hormones that are offered and have been produced. So they're a replica of what our body naturally produces. So the side effects that we experience with them aren't like they used to be, which is the progesterone and the estrogen, which you used to take in other forms, and that were actually a part of a research study called the AHCWA study back in 2002. You may not know about the study, but you probably know about what the results were. If you've ever heard somebody say, oh no, I don't want to go on to MHT because it causes cancer or it causes blood clots, they are talking about this study. It was a huge study published in the Lancet journal. It was involved many women back in 2002. The problem was the information was released prior to the study being completed, and the information was released that said it's going to cause breast cancer and it's going to cause blood clots. Overnight, women took themselves off the hormone replacement therapy. As you could well imagine, we're going to do that if that's what the case is. Prior to that, women in the UK, for instance, there was about 40% of perimenopause and menopausal women on MHT. It dropped down to 40% overnight. And even to this day, Australia and the UK are sitting around about 14% of women during perimenopause and menopause are on MHT, mostly because of the hangover of that study. Unfortunately, or fortunately, the study has been refuted many times over and over again. It does not cause breast cancer and it does not cause blood clots, but the information is out there. Many doctors who were practicing at the time and have not kept up to date are also saying still that that's the case, and women are confused about it and scared, and quite rightly. But you can be comfortable in discussing with women that that is not the case. And it's also those studies were done using the old types of hormone therapy that we just don't use anymore. So giving women more information on this study and that it has been shown that it does not increase the risk of breast cancer is really important, so they can make an informed decision about what treatments they want, and not based on past fear that was now refuted. So the way women will take hormone therapy now is usually estrogen comes in a patch or a gel, and you put it on your skin, which is bypassing the whole absorption through the liver, which is therefore not causing the blood clots. So there is no risk if you're taking estrogen via these forms on your body via a gel or a patch that you have a risk of causing blood clots. The other thing is, if a woman is experiencing bladder issues, UTIs, dry vagina, pain during sex, they can also take estrogen via a pessary on top of having the topical estrogen as well. So you can kind of double dip depending on the symptoms that a woman is experiencing. Now, the other hormone that is being used is testosterone. At the moment, the indication for prescribing testosterone is women who are experiencing low libido. So they're experiencing low libido, and that is a concern for them. That is the indication. But speaking to clinicians who are seeing many women going through perimenopause and menopause, they say that anecdotally a lot of women are experiencing benefits if they've got cognitive issues, or also that it's muscle strength as well. But there are some studies coming through at the moment that are just about to start in Australia, looking at testosterone effect with postmenopausal women on their cardiovascular health, and also testosterone effect on women with osteoporosis or osteoporotic health. And that brings me to the last thing about MHT or hormone therapy. It's looking at controlling women's symptoms now, but it's also the protective side of things that MHT is shown to be supporting for women as they're ageing. It's been shown to assist in preventing osteoporosis. Now, osteoporosis is one of those things as we get older that risks our quality of life. If a woman falls over, and women have a risk of developing osteoporosis twice as likely as men. If a woman falls over and fractures her hip as she gets older, then she reduces her ability to function well, and also as a consequence of that will often increase her risk of dying earlier because she's not going to be able to move as well. So osteoporosis is a big one that MHT is a preventative side of things, and there's also the cardiovascular health, because prior to going into perimenopause and menopause, when our estrogen level drops, prior to that, in our reproductive age, we are very well protected against cardiovascular with our cardiovascular health. The moment we go into menopause, our risk of developing cardiovascular disease increases fourfold. So that's another area to look at. And then finally, an area that's being explored now, and probably we won't get as much information in our lifetime, because you can imagine the research into dementia has to be longitudinal and can take a long time. But there is a body of evidence and a body of discussion about the preventative effects of estrogen on cognitive abilities of women, and looking at dementia, because women are also twice as likely to develop dementia than men are. So you can see MHT is really important to look at for women to understand it and at least consider it. It's not for everyone. Women who have got estrogen receptive breast cancer are a group that really would be probably ruled out for having MHT, but that is something they'd be discussing with their oncologists and also their menopause specialists. But for the majority of women, it is MHT is something that they certainly can consider and will get some really good effects from. So I hope from all that information, you've come away with some understanding of what menopause and perimenopause is, how you can help yourself and those around you that you're working with or that you know, and discussing and helping them understand the treatments that are available and the most recent information and options that are there for them.
Oh, Rebecca, thank you so much. That was
a lot of information.
That was a lot of wonderful, wonderful information. And just to let those listeners know out there that Rebecca and I actually met quite a few weeks ago for the first time. And I introduced Rebecca to a colleague that I work with here at the Aboriginal Health Council, who was actually having menopausal symptoms, and she spent some time chatting with Rebecca, has started on MHT, and she said it's the best thing that's ever happened for her for a very long time, and she's so happy. Glad. Yeah, so I wanted to let you know that. But that's so interesting about MHT. And the other thing that's very interesting is that there are women that have been going to GPs and saying that they're having these symptoms, and then they do the blood test, and the blood test says that they're not menopausal. So then the poor woman leaves and thinks, well, what the hell is going on for me, you know? So really fantastic that it's now, you know, diagnosed through symptoms. And for people who are listening to this bite, they can download that symptoms checklist from the Your Menopause website, which is actually on the screen now. Is that correct, Rebecca?
That's correct. Yeah, if you just go to the Your Menopause website and go to blogs, and you'll see there it's a symptom blog, and you just download it off there.
Okay, wonderful. All right. Well, thanks again, Rebecca.
My pleasure.
I think that menopause is probably worth another bite, to be honest. There's so much we can talk about, but thank you so much for joining us today.
My pleasure. Thank you for having me.